Hello everyone, I'm going to do a quick education on anaphylactoid syndrome of pregnancy, or as we formerly knew it, amniotic fluid embolism. This was one of our maternal code scenarios, and we discovered we don't have a lot of knowledge on it because it's not something that we see often, thank goodness, and also because we've reviewed it once before in the past, and so it's not something that we've really revisited. So we're going to revisit it for the skills fair. The virtual skills fair. So anaphylactoid syndrome of pregnancy is interchangeable for amniotic fluid embolism, and they're trying to go to ASP more. It is a mouthful of words, however, it does pinpoint the description of the disease process better than embolism. When we think embolism, we formerly think like a clot or something that's blocking, and whenever this happens, it's actually not an emboli of any type. So it's the leading cause of maternal morbidity or mortality behind cardiovascular and hypertensive disorders of pregnancy. So even though this doesn't happen very often that we see, it is a leading killer. Survival rate has improved to only 15% of patients who experience this to be deceased versus previously 86% of people with this disease process presenting would die. And it happens in 1 to 20,000 to 1 in 80,000 pregnancies, which when you think about our facility, you're like, wow, that would take a long time. However, when you think of the grand scheme of how many deliveries and pregnancies there are in America, it's a little bit more common than you think. So we deliver at Titus about 1,000 babies a year. So by the minimal standard of this ratio here, we should have one patient with an amniotic fluid embolism or ASP every 20 years. And I would be happy if we had even less. So if it's not an embolism, what is it? It is a pro-inflammatory response. So just like an allergy type reaction occurring with the release of cytokines and arachidonic acid metabolites as the cell signaling molecules for prostaglandins, which control the process of inflammation. So we're actually looking more at an allergy inflammation type situation that starts a huge cascade of events in the body. It is rare and sudden. Amniotic fluid will enter mom's circulation. So this could be during pregnancy via uterine or cervical tears, amniocentesis prenatally, DNCs for those patients who have later SABs, C-section delivery. You can see kind of down here the whole cascade of what goes on. Risk factors for this is advanced maternal age. The risk actually doubles here. If you have a disease process like eclampsia, diabetes, if you have an amniocentesis done, of course, as I said, placenta previa or placenta abruption. This can also be maternal trauma, especially maternal trauma that occurs to the abdomen. So when you think about those moms who are in MVAs or in domestic violence, this could also be a very possible scenario. And of course, just with anything, if you induce a patient into labor, you're increasing the risk of many things. One of those is a amniotic fluid embolism or anaphylactoid syndrome. So short-term symptoms, you're going to have shortness of breath. The patient's going to have a blue hue to her skin, and then she'll immediately start trending into respiratory arrest, ARDS. You'll see a left-sided heart failure because of pulmonary artery constriction. That leads ultimately into a full cardiac arrest, which is why we use this scenario for our maternal codes, or one of them anyways. So with the decreased oxygen, you're going to see mom becoming confused, agitated. She may seize, go into a coma, and eventually have an anoxic brain injury. Uterine atony accompanies this, leading to an uncontrolled hemorrhage, DIC, and then metabolic acidosis. So this is where when the one thing with anaphylactoid syndrome goes wrong, you start cascading down. And then as you start bleeding and going into DIC, you reach a hemodynamic shock because of blood loss and also a hypotensive shock resulting from the fluid loss after DIC development. So this is why it's really rare for these patients to survive. This also happens relatively quick. So morbidity is significant. So if you do have that patient who survives an AFE, then she will have some type of morbidity 85% of the time. It is a very, very, very small population who survives this and then has no implications moving forward. So the most common is encephalopathy and brain injury, and may require ventilation or mental health support, maybe in a vegetative state for the rest of their life. You may have to work with a hysterectomy to control the bleeding. Again, that's emotionally tragic for those involved. In the future, if they're able to have children they survive, they're likely to have preterm cesarean birth. And then, of course, an increased length of stay, ICU admissions, and then a greater risk of healthcare-associated infections because of their disease process and their stay in the hospital and ICU. So after birth, the effects are minimal. If this occurs, once the baby is out, the effects as far as that are more so bonding interruptions and difficulty with feeds. During pregnancy, you're going to obviously see fetal distress. You'll have lates, bradycardia, and need to do a stat C-section or, as in our scenario, a perimortem C-section. Apgars tend to be lower in the neonate, of course, because of the lack of oxygen. Low fetal pH on your ABGs. You may even see neuro injury and a severe hypotension or a baby that's in shock once it's born. So 50% of these babies experience permanent neurological injury if their mom experiences an AFE before birth. Early recognition is the key in this. There's 4 cardinal signs, so that respiratory decompensation, altered mental status, confusion, hypotension, and then DIC. This is not just known to be right at birth or right before birth or at those risk factor times, but this has also been known to occur up to 48 hours after birth, which is why it's really easy to get lax when you have a postpartum patient. However, it could go really bad really fast. And so just because a mom had a normal vaginal delivery and is doing well does not mean that you don't need to watch those Muse triggers and really watch for a change in her affect or behavior. As far as diagnostics, there is no gold standard. This is one of those things you just see almost and know what's going on. So suggested diagnostic criteria are, of course, sudden arrest. So this is if your mom's coding, this is one of the things you want to think about. The visual indication of DIC, clinical onset during labor or within 30 minutes of placental delivery, if it's hanging out around that time frame. And then also, if she had no fever during labor, she's also at a risk, which is interesting. Managing these patients is ultimately to maintain their oxygen levels, ACLS, of course, if they arrest, transfuse for DIC, and the AOK regimen. This is a newer regimen that they're coming out with. It's not something that sits and rests in our labor and delivery brain, so I want to bring it up in case you ever, hopefully you don't, but if you ever have this happen, the AOK regimen is atropine 0.2 to 1 milligrams, Zofran 8 milligrams, and ketorolac or Toradol 15 to 30 milligrams. And so again, looking at the pathophysiology of the disease, you have the sensitization and you've got the allergic response. And so you're looking at the atropine and the Zofran inhibiting serotonin and vagal stimulation that improves cardiac function and vascular tone, therefore increasing cardiac output, which is important because we know that their heart is decompensating. And then the Toradol inhibits thromboxane, which can block the cause of coagulopathy. So that will block the crisis going on with the bleeding on the inside. So this is one of those regimens that's come out that is increasing that percentage of patients who are living and surviving anaphylactoid syndrome of pregnancy. Post-resuscitation care for those moms who make it. We want to obviously get them some respiratory support, maybe get them on a ventilator and ICU. Vasopressors for their blood pressure, targeted temperature management, especially if they coded, get them somewhere where they can have that. Continue postpartum care, continue the bonding component as much as humanly available. Try to get those moms, if they're wanting to breastfeed, get a pump to their bedside. Even if you have to do the pump on them the whole time, it's very important that they don't miss out on the things that moms should experience after having a baby if they're able to, or if they're able to with your help. So that is all for amniotic fluid embolism or anaphylactoid syndrome of pregnancy. If you have any questions, please let me know.